Dr. Sean Gray will be next, one of our shoulder specialists.
There you go. What you got? Let's advance.
Advance, yep, below it is the...
Okay. Good morning. Thank you guys for being here on a snowy Saturday. We've got these trees up here to make it better, though, so it feels pretty tropical. I'm going to get my slides up here. I'm going to talk to you about some of the changes that have occurred in the last few years in rotator cuff surgery. See if this goes. We may want to go back a couple here. There we go. So, no catchy name. Just we're going to talk about the changes that have occurred with rotator cuff surgeries in the last several years. These are my significant financial disclosures. They gave me too much time to talk when I start with my first slide. Doesn't have anything to do with shoulders, much less rotator cuffs. And this is a Dunning-Kruger effect, which my guess is a lot of you guys are probably familiar with that. For those of you who aren't, it basically says that, when you first start learning about something, you don't know anything about it. As you learn more and more about it, your confidence in that grows. And then there's an inflection point where a funny thing happens, that the more you learn about something, the less confidence you have in that. And I think you maybe heard that like in Rockies' talk today, is he knows more about ACLs than anyone I know, but you can hear he says, hey, we're not sure about a lot of things. And so this was taught to me by a mentor of mine. He said, when you go to a scientific meeting, everybody wants to listen to the guy who pounds on his chest and says, hey, here's what the problem is, and this is what our only solution is. But you probably sometimes want to listen to a speaker who maybe says, we're not so sure what's going on, and at this point, this is what we think is best to do. The reason I say that is I gave this same talk in 2017. I went back and looked at it. 60 to 70% of the things that I have in this talk today weren't even around when I gave that talk. So rotator cuff disease. This is a huge spectrum of disease. So unlike a lot of other things that we talked about that have a name like ACL tears or talar fractures, where that all fits into a pretty narrow window, when people say they have a rotator cuff tear, that could be a huge difference. Anything from a very small partial tear in the rotator cuff to tears of different tendons of the rotator cuff up to these massive cuff tears that lead to degeneration of the shoulder. And so if we take 5 people in this room here who go out at the break session and sit down and they all have a rotator cuff tear, they may all have 5 different treatment options with that, right? Somebody may have no pain and not need any treatment at all. Somebody may be so bad that they need a joint replacement. And so there's a huge spectrum of treatment that goes along with that large spectrum of disease. So for today, I'm going to talk about a couple of the things that are new for us in the last several years here. 3 of those things: biologic scaffolding, a reinforced biologic graft, and then this interpositional balloon that we use. The last thing I'm going to talk about, reverse replacements. I'm going to talk about the mechanics of that, because the second most common question I get asked, besides how tall I am, is how does a reverse shoulder make up for the rotator cuff? And so in terms of biologic scaffoldings, we'll talk about this bovine collagen patch. And then for reinforcing difficult repairs, we have an augmented kind of version of that. And then there's a balloon that you can use in irreparable rotator cuff tears, and then again, the mechanics of a reverse. Why is this important? Rotator cuff's extremely common. When we look at people over 40, if you take all people over 40, probably the incidence of rotator cuff tears is somewhere between 10 and 20%. That obviously increases as age. A lot of those rotator cuffs aren't symptomatic or minimally symptomatic and don't need treatment. But even with that being said, in 2021 in the United States, over 500,000 rotator cuff repairs were performed. Cost the economy about $5 billion. Some in expense of taking care of those patients, but a lot in lost productivity because the recovery time is long for this. Why do rotator cuffs tear? Well, this is really a degenerative process, not a traumatic process. What happens is when we're young, we have really good blood supply where the insertion of our rotator cuff is into the humeral head. As we get older, that blood supply recedes and you get a watershed area in there. And so that as you have daily forces put upon that trauma, or daily forces put upon that tendon, it's not able to recover from those forces, and the tendon degenerates. And then you have a tear with an injury you could have had 3 or 4 years ago and been fine, or kind of like getting a hole in your t-shirt. You look down one day and there's a tear. And so about 60% of the patients I see have no history of trauma. What happens once you have a rotator cuff tear? Well, the natural history of that is that if it's a full thickness tear, it's going to likely get larger, not all the time, but most of those will get larger, and so the tear will get bigger. The success rate with fixing it will decrease with time, and then those can lead to massive irreparable cuff tears that leave us more limited options in treatment. We're not going to really talk about diagnosis today, but a couple things I wanted to make notes of is obviously the primary presenting symptom is pain. One thing to listen to is night pain. A lot of times when people go from having tendonitis to a tear, as soon as they start complaining of night pain, your clinical suspicion for a cuff tear should go up quite a bit. And while weakness like this lady here on exam is what everybody thinks, I can tell you a lot of patients with pretty significant cuff tears have normal strength, normal function. So just because somebody's not weak, I wouldn't say, hey, you don't have a rotator cuff tear, and we'll see some people who had pretty significant delays in treatment because they didn't present with weakness. If you have suspicion, then going to an imaging study is helpful. There's a lot of imaging studies, but really by far and away the gold standard is MRI. I always tell patients this is a complex medical imaging and requires sophisticated interpretation. And so a lot of that is that it's limited value if it's not taken in the clinical context that it occurs. You know, age of the patient, activity, how symptomatic they are. And I'm always wary of MRI reports. What I'll tell you is that these 3 MRIs all had identical reports. And when we look at it in this patient, a really small partial intrasubstance tear, may not need anything done, but certainly would start off with conservative management. In this patient who has this traumatic tear, okay, acute, good quality tissue starting to retract already, you probably want to be pretty aggressive about repairing it. And then in this patient who has this chronic tear where the tendon's retracted significantly back, that patient, you know, may be somebody that you're going to, again, switch back to wanting to treat non-surgically and see how they do, because our treatment options are going to become more limited. So we'll talk first about partial thickness cuff tears. This is the great group that's going to have the greatest variability. You know, it's going to depend on their symptoms. If they're asymptomatic, don't have to really do anything with it. Injections, this is an area where a role of biologics can be very helpful. We can do a full repair, and then I'm going to talk to you about this biologic scaffolding graft in a minute. Again, majority of these patients we can treat non-surgically. Just a quick word about biologics. This could be an entire talk here, and probably should be. I think this is an area that has a very promising future, not only in non-surgical management, but in augmenting our surgical repairs and in modulating the post-surgical healing response. I don't know that the science is there yet. Again, I'm not a hater at this point. I think that we need to learn the chemical messages that tell the cells what to do, and I think that's going to come for us in the next 4 or 5 years. So when I say things are going to change, I think the biggest part is going to be on the biologics side of rotator cuff healing. And I think biologics, PRP, BMAC are going to make a big difference in that. So what is this biologic scaffolding? Well, this is essentially it's a cow's Achilles tendon that was thrown in a blender and they grind it up and you got this collagen patch. It's not structural. That's the important thing to understand about it. It's just a scaffolding that allows cellular tissue to grow in it and thicken the tendon. And so we have an articular-sided tear here with the yellow area. And the reason you probably have pain is that those remaining bursal-sided fibers are being overloaded. And so where the tendon's normally about 8-9 millimeters thick, we get this partial tear, and now we got a tendon that's about 3 or 4 millimeters thick, and those 3 or 4 millimeters are taking up too much force, and it's painful for them. And so what we do with this graft is go in and we just clean up the tear on the articular side. We don't do anything with that articular-sided tear, and we put a graft arthroscopically. You bring this in, it's got a neat system, you deploy it on top of the tendon, we put it on top of the tendon, and then that acts as a scaffolding so that over about a 6-month period, that begins to incorporate, and so that the goal of this is, at the end, now you're back to a tendon that's 8-9 millimeters thick. And so I don't have MRI that reproduces very well, but if you look on the far right side, kind of that's got a normal footprint of the tendon after you had a very thin tendon with that before the grafting. So what about full thickness cuff tears? For patients who are under 70, they're active, they're healthy, they got good tissue quality, they're symptomatic, and it's a reparable lesion, the vast majority of these repair. People who don't fit into that criteria, then again, we begin to think about non-surgical treatment. It's a small group of patients that are under 70 that are asymptomatic that have a full thickness tear. And those patients, I am okay watching them, but I will maybe repeat an MRI in a year to make sure we don't see tear progression. And if we have tear progression, then I give them information and let them make an informed decision about what's happening. If we don't see progression in the tendon tear, then I think continuing to watch them is fine. And so what are our goals when we do a rotator cuff repair? There's really 2 parts to the operation. Everybody focuses on the mechanical part, us sewing the tendon down to the bone, but the important part is the biologic part. We need that tendon to heal to the bone, but what really happens is the tendon doesn't heal to the bone needs to heal to the tendon, because we talked about the reason these tear, poor blood supply in the tendon, and so all the healing elements sit in the bone. And so, you know, basic goals here. So here in this is a scope picture, we're looking from behind, that's our humeral head. really big cuff tear, okay? And then this is the footprint on the greater tuberosity, so on the humerus where we want to get that tendon to heal. And we prepare that bone, and what we've gone to on most of these now is this double row repair where we go over a wide area and try to get as much tendon into that healing surface of bone as we can. So just a video of this to kind of show you what we do on a standard cuff repair here is I've passed all my medial sutures, and now I'm tying down my medial sutures. Again, getting fixation on the inside side of the tendon where the tendon tore away from the bone. But you'll see in a minute here what we're going to do then is we're going to take those tendons from the medial side. We're going to loop those over to anchors that we'll put out here onto the lateral aspect of the humerus so that then these sutures press all that tissue down into the bone. And you can kind of see just on the edge of that scope picture, I made holes in the bone because then bone marrow is going to come up through there. And again, that's where the healing elements are. All the healing occurs from the bone onto the tendon, not the tendon onto the bone. So again, our idea is we want to get a wide surface, a footprint area for that to heal. So what do we do in more difficult situations like the picture that I showed you, that massive cuff tear? We're going to come back and show what we did extra with that. Or if we've got poor quality tissue, which is a common thing, we'll see these delaminated tears where you've got this tissue here, but again, that tissue is probably 2 or 3 millimeters thick, where this is our normal rotator cuff here, okay, at 8 or 9 millimeters thick. I'm not getting that tissue all the way back over here when I go to repair it, right? So I need something, if we're just going to repair that wimpy tissue, we need something to reinforce and add to that, okay? Graft augmentation became popular about a decade ago. Most of those, we use dermal, for the last 10 years it's been dermal matrix graft, so it's basically made out of human skin, kind of like carbon fiber that you lay in multiple layers to make it strong. Number of studies show pretty significant improvement in the most complex rotator cuff tears. We see improvements anywhere from 40% in outcomes to getting them back up into the 90th percentile, which is what we see with regular rotator cuffs. And so because of the success rate with the dermal grafts, this has become an extremely crowded space. In the last 3 or 4 years, there's a number of products that have come out that are trying to address this. Again, this one is what we showed earlier. It's kind of that dermal graft, the skin graft we sew on top, and then we had just gone through the Regeniten. The problem with that is that, again, like I told you, that's not structural at all. All that is a scaffolding to help maybe thicken a tendon, but it's not going to provide strength to our repair. So this is one of those grafts that we tend to use. Again, it's a graft that's a ground collagen matrix, okay, but in addition to this, it has polyglycolic acid, which if you look and kind of see the woven surfaces on the top of that PLA is very strong initially, and then over the first 12 months, it resorbs and the strength decreases. So basically, the graft will load share or take pressure off of the repair initially, and then over time, as the graft resorbs, it transfers that force to the tendon with the idea then the tendon gets strong under the force that it sees. That's my finger, and I got a big finger, but not that big of a finger. It's a pretty small graft. And so, again, here's our tear that we talked about. Okay, we did our double row repair. Okay, again, our double row repair underneath, and then we're going to sew this graft on top, and we're going to get fixation here, medial and lateral, so that it load shares and unloads the strength of the graft. And so this is doing it intraoperatively. We've kind of got these sutures that we kind of do a fancy way of passing this into the joint. And then once the graft is deployed into the joint, I'll go back, I'll retrieve these sutures that we used to pass it immediately, and we'll tie those down medially and get fixation. And again, you can see it's better on the video. You can see that PLA, that's the part that provides the strength to the graft, and that's the part that's going to resorb. And then like what I showed you with the other graft, the rest of the stuff underneath that's more opaque is collagen, and it should allow for thickening of the tissue. And so we've used this now on a number of really complex repairs. We've just entered into a multi-center trial where we're going to do this in a randomized trial looking at patients with average standard repairs and see if this improves recovery time, speeds recovery time, and improves outcomes. So what do we do when the rotator cuff tear gets so big that we can't fix it? Well, again, a lot of these patients we can potentially manage non-surgically. If they're not super symptomatic, again, depending on age and function, we'll manage them non-surgically. We'll talk about some soft tissue procedures, which for the last 15 years, kind of the workhorse of that's been something called a superior capsular reconstruction. We got multiple muscle transfers, and then I wanted to talk about something that's new and probably a lot of the therapists have seen and wondered about, which is an interpositional balloon spacer. And the ultimate treatment and the best outcome with that is a reverse replacement. But again, that's replacing somebody's joint, okay? And that's going to have the most reproducible outcome, but it's going to come with all the issues of having a replaced joint. And so if you're younger, more active, maybe not overly symptomatic, that may be more than what you need. So I said I'd talk about reverse mechanics and shoulder mechanics, which I think makes all the other operations make a lot of sense. And so what a lot of people think is their rotator cuff lifts their arm up. It doesn't lift your arm up. What lifts your arm up is your deltoid, okay? And so your deltoid is just a muscle. When that contracts, okay, it provides a superior migratory force onto the humerus, okay? And so the job of the rotator cuff is that it just centers the humeral head on the glenoid, so you got a center of rotation, okay? So that now when the deltoid contracts, you got a pivot point and you're able to abduct your arm, okay? What happens when you have a massive cuff tear is the deltoid contracts and all that force to the humerus is transmitted in the humeral head just riding up high. And so really the job of the rotator cuff, its only job, it's a stabilizer of the shoulder. It resists the superior migratory force of the deltoid. And all of these surgeries are based kind of on that principle and philosophy. So again, you know, here in a normal shoulder, what we see, center of rotation of the glenoid is right in line with the center of rotation of the humerus. As we get these massive cuff tears, we lose superior restraint to the humeral head migrates up, and then you get an x-ray, and here's the center of rotation of the humerus, here's the center of rotation of the glenoid. So we need to restabilize that shoulder. And so what we do with the reverse replacement is it's a pretty simple idea. You just invert the concavities of the joint so that we now have a metal ball on the socket side and a socket on the arm bone side, and by doing that, you resist that superior migratory force, so that now when your deltoid contracts, okay, you got a fixed fulcrum point and you're able to abduct your arm. And so here's kind of typical patient with pretty significant cuff tear. You see he can't even hold his arm up against resistance. And again, we don't do anything soft tissue, which is what the patients think. We go in and repair some of the tissue that's torn. We don't. We just do the reverse replacement. And then here he is, you know, even at 3 months, their strength comes back really quick because they don't have soft tissue that needs to heal, which most of the therapists kind of understand this. And strength is really good right off the bat because his deltoid is fine. You just need to get his deltoid in a position where it will work. So what do we do for massive cuff tears in younger patients who are more active, you know, and function better when we don't want to be aggressive about doing a replacement? We can do a superior capsular reconstruction, which how I describe this to my patients like a reverse trampoline. Again, we got that human dermal skin graft, but now instead of tying it from the rotator cuff to the tuberosity, we're tying it from the glenoid to the tuberosity. So again, it's like a trampoline. It just prevents superior migration of the humeral head. Very long recovery, okay, because it takes a long time for that graft to incorporate, and about a 70% success rate, so not a perfect operation. We got a bunch of different muscle transfers that we can do. Kind of the new sexy one is the lower trap transfer. And again, all of these work the same. You know, they just work like a reverse, right? All they're doing is stabilizing the humeral head, depressing it, okay, so that we restore the subacromial space and stabilize the center of rotation for the shoulder. And so the new thing that's out, it's been out I think probably about 18 months now, is this biodegradable balloon spacer that goes into the subacromial space. And so pretty easy to perform arthroscopic operation where you just clean things up a little bit. You put this balloon in deflated, you add saline and you inflate the balloon, and the balloon works to become, to restore your subacromial space and again push the humeral head down, okay? The indications for that are pretty limited. I think this is not a motion gaining or strength gaining operation as much as it's a pain relief operation. So for me, most patients need to have full range of motion and only maybe moderate weakness. You have to have an intact subscapularis and not arthritic changes. And so when you take that group of patients, that becomes a smaller group of patients to do it on. Again, it's technically easier to perform. For all the therapists who've been here, you know it's very easy from a rehab standpoint. In comparison to a regular rotator cuff. It is a much less predictable outcome than a reverse replacement, but again, fairly simple to perform with very little morbidity or downside to it. The balloon, this is the complicated part, the balloon resorbs somewhere between 3 and 6 months, so why these continue to work afterwards, really we don't honestly know the mechanism. We think that there's probably a subacromial scar tissue that forms around that balloon, and as the balloon resorbs, that acts as an acromiohumeral spacer afterwards. That's been in Europe for a while, and, you know, and they have cases where people who've done well for 5-10 years, they can repeat that in there. There's pretty good clinical data with that. Again, I think this is a limited group of patients, unfortunately, and a lot of those patients are over 65, and Medicare doesn't pay for it, so I think a lot of patients who I think would be probably decent candidates for that are maybe not economically allowed to do that. I do think this is super easy to perform, and I've already seen a number of cases of this is done in people who don't have appropriate clinical indications, so that's one of the things we need to be cautious with that. In conclusion, rotator cuff disease encompasses this really broad spectrum of pathology, so we need multiple treatment options to address that. We've got multiple options now that are available to us that weren't even available 5 years ago. I think this is a space in which there's going to be a lot of changes, and we're going to see a lot of changes, particularly on the biologic side of this over the next 5 to 10 years, improving the biology of this to improve outcomes and hasten recovery. And lastly, thank you guys. A lot of therapists here who I was talking with Kevin Rose back there. I do the easy part. It only takes me about an hour. You guys work with these guys for months and make me have good outcomes. I appreciate that. For the primary care doctors who send people and trust us for their care, I appreciate that. And you guys for listening to me on a Saturday longer than my kids would ever listen to me. I appreciate that. So thank you guys.